Hello everyone, welcome back. The topic for today is bisecting angle technique. Now in my last video, I have covered about periapical radiography. In that I have talked about indications, aims and limitation of periapical radiography. So in that video, I have said there are two methods of periapical radiography, that is bisecting angle technique and paralleling angle technique. So starting off with the first technique, that is the bisecting angle technique. So it is also called as short cone technique and it is based on the principle of isometry. Isometry is defined as it is the equality of the measurement and it is the most commonly used intraoral radiographic technique, that is your bisecting angle technique, and the one which we are usually doing in our clinics or in our colleges is this same only, that is this bisecting angle technique. Now, what is this theory of bisecting angle technique? So it follows the Szymanski rule. It is based on the principle of geometric theorem of Szymanski rule, which states that two triangles are equal when they share one common side and they have two equal triangles. So this is based on the Szymanski rule, and Szymanski rule is nothing but the two triangles, they are equal. So for example, these are the two triangles. So they are equal when they are sharing a common base and they are completely equal triangles. So now you can see in this diagram, they follow this same base and they have 90-degree angle. So this is nothing but the Szymanski rule. So in this, the film, it is placed as close as possible to the tooth without bending the film. So in this, the film, it is placed as close as possible to the tooth. Then the angle which is formed between the long axis of the tooth and the long axis of the film, it is assessed. So this is your long axis of the tooth and this is the long axis of the film. So the angle which is formed between them, it is assessed. Then an imaginary bisector, it should be drawn between the long axis of the tooth and the film. Then this is the imaginary bisecting line which is drawn. So this is the bisector which is drawn between the long axis of the tooth and the long axis of the film. Now you can see there are these three lines. Then the X-ray tube head, it is positioned at the right angle to the imaginary bisector and the central rays, they are passed through it. So then your X-ray tube head, it is positioned in such a manner that it is right angle to this imaginary bisector and then the central rays are passed through it. Now you can see over here there are these two triangles which are formed and this is the common base which these two triangles is sharing, and these are equal and hence it follows this Szymanski rule. So this results in the formation of two right angle triangle. So this helps in the formation of two right angle triangle. Now if the X-ray beam, it is directed at the right angle to the film, the image produced is shorter. So now if your X-ray tube head, it is positioned perpendicular to the long axis of the film. So now this is the long axis of the film. And if your X-ray tube head, it is positioned like this in right angle to this X-ray film, then the image which is produced, it is shorter. And if this X-ray beam, it is perpendicular to the long axis of the tooth, then the image which is produced, it is longer. It is elongated. So the central rays, they should be perpendicular to this imaginary bisector and not the long axis of the tooth or not the long axis of the film. So when the rule of isometry, it is followed strictly, the image produced is accurate. So when you are following this rule properly, then the image which is produced, it is accurate. And the target to object distance in this technique is 8 inches. So now what is the patient's position? The patient, they should sit upright in the chair and the height, it should be adjusted at the workable length. The patient's occlusal plane, it should be parallel to the floor. So this is the occlusal plane and it is parallel to the floor, and the mid-sagittal plane, it should be perpendicular to the floor. This is the mid-sagittal plane, so it is perpendicular to the floor, and the occlusal plane, it is parallel to the floor. What is the head position of the patient? So the patient's head, it should be properly supported by the headrest. So the patient's head, it should be supported properly by the headrest to minimize the unwanted movements. Now for maxilla, the chair is usually raised, and for mandible, the chair, it is lowered. Now the occlusal plane, in case of maxillary teeth, the reference line for the occlusal surface, it should extend from the tragus to ala, that is the ala tragus line. So as a reference, like exteriorly reference which you are taking for the occlusal plane, now you cannot open the patient's mouth while taking a radiograph and you're going to see where exactly the occlusal plane is. So exactly externally you're taking a reference of it. So for maxilla, you're taking a reference of the ala tragus line, and for the mandibular teeth, it is from the corner of the mouth to the tragus of the ear. So this is the line for the mandible and ala tragus line is for the maxilla. In maxillary radiographs, the head position, so in maxillary radiograph, the patient's head position is downwards, and in mandible, the chin is moved upwards. So this is the position. So if it is for maxilla, this position is known as upper horizontal baseline, and this is known as lower horizontal baseline. After that, you are asking the patient to wear a lead apron or a thyroid collar, and then you are explaining the procedure to the patient. Now moving on towards the film placement. So the smooth white surface of the film, it must face the X-ray tube head with orientation dot occlusally. This is the smooth white surface of the film, and it is placed towards the X-ray tube head, and this is your orientation dot, and it is placed occlusally. It is also known as occlusal dot. So this occlusal dot, it will come on the upper side if you are taking for mandible, and it will come on the lower side if you are taking for maxilla. It is because your occlusal plane will come at that side only. So the film, it is placed vertically for anterior and it is horizontally for the posterior. And this occlusal dot, it also has one more importance, that is it also helps in deciding or detecting which exact the side is. So it can help to detect the left or the right side of the arch. So this occlusal dot, it has a convex and a concave surface. So convex is also known as a pimple, or the concave is known as dimple. So this convex is towards the doctor and the concave side is towards the patient. Now how you're going to stabilize the film? So there are these three ways in which you can stabilize. So first is the snap array film holder. This is the normal film holder. The next is the Rinbay, that is the bisecting angle instrument, and the next can be the patient's finger as a film holder. So this is the patient, he is asked to hold the film and it acts for the film stabilization. So the patient's thumb, it is used for stabilizing the film. And so basically for the maxillary radiographs, so the patient's thumb is used for stabilizing it, and for the mandibular radiograph, the index finger is used for stabilizing the film. But there are the disadvantages of it. It can be radiation exposure. So the patient's hand, it is exposed to the radiation. The next can be bending of the film. The film, it can get bended. Next is the slipping of the film. Then there can be chances of cone cut. Then if the patient is a child patient, so in case of child patient, it is very difficult to obtain the cooperation in holding the film with their finger. Then the next disadvantage is stability of the patient. It is difficult for the patient to hold the film with one hand and maintain the stability. So this is all about the film placement, how you're going to place the film in a bisecting angle technique. Next is the vertical angulation. So what is this vertical angulation? It is the position of the X-ray tube head in the upward and the downward direction. So how exactly you're going to place the X-ray tube head, which direction? Then the positive vertical angulation is the angulation in the downward direction, and the negative vertical angulation, it is the angulation in upward direction. The vertical angulation, it varies according to the position and the inclination of the teeth. So if the teeth, they are proclined, it requires more vertical angulation than normal, and if the teeth, they are retroclined, they require less vertical angulation. And the angle, it increases in both the extremity of life. In children, it is because of the less height of the alveolar process, and in the edentulous, it is because of the resorption of the alveolar process. So there are this incorrect, if you're not taking the radiograph with proper vertical angulation. So incorrect vertical angulation, it can result in foreshortening and elongation. Foreshortening is in the case of increased vertical angulation, shortening occurs of the image. So this is the foreshortening. When the vertical angulation is increased, it causes the foreshortening of the image, and if there is decreased vertical angulation, it causes elongation of the image. Now this is the fixed vertical angulation for bisecting angle technique. Now for maxilla, if it is for anterior, for the incisor, it is plus 40. The angulation is 40. For canine, it is 45. So basically, it's like reducing from your anteriors to the posterior. So it is 40, 30, 20 by 10. It is reducing by 10, but it is usually more for canine because of its long route. So for incisor, it is plus 40. For canine, it is plus 45. For premolar, it is plus 30, and for molar, it is plus 20. And for mandible, it is minus 15 for incisor. Now in this, it is reducing. Again, it is reducing from the anterior to the posterior. In mandible, it is reducing by 5, and in maxilla, it is reducing by 10. So again, for canine, it is increasing by 5 because the longs are rude comparatively. And the angulation, there's a change in the angulation of your arch because of this canine, at this canine. Then the mandible, in mandibular, the incisor is minus 15. And as we have seen, negative vertical angulation, it is the angulation in upward direction. So you're positioning your X-ray tube head in the upward direction. So it is minus 15, canine is minus 20, premolar is minus 10, and molar is minus 5. So you have to learn this like by heart because you have to do the vertical angulations in this bisecting angle technique depending on this angulations only for this particular tooth. Now moving on towards the horizontal angulation. So it is the angulation of the tube in the horizontal plane, that is side to side direction. So if the horizontal angulation is incorrect, it leads to overlapping in the proximal contact area. So this is nothing but the horizontal angulation, how you're placing your X-ray tube head in the horizontal direction. Now what are the disadvantages and advantages of it? Advantages is it is comfortable positioning of the film. So the positioning of the film packet is comfortable for the patient in all areas of the mouth. It is a simple method. Then the next advantage is the adaptation. So it can be adapted according to the shape of the most dental arches. Then there is no sterilization. No sterilization of the holder is required as they are not very much used. Then decreased exposure time. Less exposure time is required in the cases of bisecting angle technique. Then the next advantage, if the patient he is uncooperative, in that, as you know, the exposure time is reduced. So in that you can take the X-ray like fastly in such patients. So if it is done properly, the image length it remains the same. As we have seen, if you are keeping your vertical angulation properly, then the image length it remains the same. Now what are the disadvantages? First is image distortion. So the various variables which is involved in the technique may result in the distorted image. So another reason behind this is that the film and the object they are not parallel to each other, and because of that there can be image distortion. So there can be foreshortening and elongation as we have seen in vertical angulation. The next is the periodontal bone level. The periodontal bone levels they are poorly represented. Then there can be overlapping of the shadow of the zygomatic bone. So the shadow of the zygomatic bone, it is generally superimposed over the roots of maxillary molar. Then there can be angulation problems. The horizontal and the vertical angulations have to be assessed for every patient, and the considerable skill is required. So in this, like you require good skills to take a proper bisecting angle technique, through this bisecting angle technique to take a proper radiograph. Then there can be cone cutting. So coning off or the cone cutting, it may result if the central ray it is not aimed at the center of the film. So in this, as we have seen in the projection geometry, your film it should be positioned center to the center of the tooth which you are taking. And if you're not taking the radiograph properly, if you're not positioning the film properly in the center, then it will lead to cone cutting. Then there can be overlapping in the proximal areas. Now we have seen in horizontal angulation, if the horizontal angulation is incorrect, it may result in overlapping. Then there can be distorted crowns. The crowns of the teeth, they are often distorted, and this prevents the detection of the proximal caries. And then last can be the foreshortening of the buccal roots. The buccal roots of the maxillary premolars and the molars, they are often foreshortened because of the incorrect angulations. Now this is the last part of it, that is the Lee master technique. So it is the modification of the bisecting angle technique which is done in the case of a prominent malar bone. So if the malar bone is nothing but the zygomatic bone. So if the zygomatic bone, it is prominent, in that you are doing this modification of the bisecting angle technique. So the basic principle is same as the conventional technique of the bisecting angle technique, that is the Szymanski rule of isometry. So this also follows the same rule, that is the Szymanski rule. But in this, if the X-ray it is projected in the molar area at the normal angles, the normal angle is nothing but it is plus 20, it is between the range of plus 10 to plus 20. It can result in the superimposition of the bone. As we have seen, this is the disadvantage of the bisecting angle technique. So it leads to superimposition of the bone over the roots of maxillary molar. Now in this technique, what you're doing is you're placing a cotton roll in front of the film. So this is your film, you're placing a cotton roll in front of it, which rests against the palatal surface of the molar. So this cotton roll, it rests against the palatal surface of the molars, making the mean plane of the film more parallel to the plane of the tooth. So as we have seen, your film, it is touching more towards, so it is placed as close as possible to the tooth. But in this, you're placing a cotton roll so that it becomes a bit parallel to the plane of the tooth. So because of this, now you can see it is getting parallel rather than getting that triangular shape. Then the vertical angulation, it is decreased in this technique by 5 to 10 degree to avoid the superimposition. Now this, like how much it should be decreased, it is dependent on the distance between the occlusal edge of the film to the occlusolingual line angle of the tooth. So this is the linguo-occlusal line angle. So if the distance between it is 5 mm, then it is reduced by 5 degrees, and if it is the distance between these two is 10 mm, then it is reduced by 10 degrees. And this was all about bisecting angle technique. Thank you so much.